me ask you something before starting the video, that if a patient sat in your chair right now and somewhere in their mouth there was a cancer growing, would you catch it? Most dentists say yes, but the survival rate of oral cancer is still 50%. That means half the patients who get diagnosed do not make it past 5 years. So, somewhere between yes, I would catch it, in reality, something is going wrong. Today, we are going to fix it in this video, but before starting, please subscribe our channel as I am doing my best to deliver the simplest concept to the students. Now, coming that what is it? So, squamous cell carcinoma. Say it out loud because this is the one that matters most. It accounts for 90% of all oral cancers. Yes, 90. Everything else combined is just 10%. It comes from the stratified squamous epithelium lining your mouth. Usually, it starts as a dysplasia, abnormal cells building up slowly, and then one day those cells push through the basement membrane into the connective tissue underneath. The moment that happens, it is no longer just a lesion, it is cancer that can travel. Coming at the statistics. Now, I want you to sit with these numbers for a second. 30,000 new cases every single year just in the United States. 3% of all cancers in males, 2% of annual male deaths, and that overall survival rate is 50%. I know we throw statistics around a lot in medicine, but think about what 50% actually means. If you lined up 10 of your patients with oral cancer, 5 of them will not be alive in 5 years. This is not a number you forget easily, and it is the exact reason this topic cannot be revised the night before your exam and then forgotten. Coming on the common sites, okay, so where does this actually happen? Because this is the part most students get wrong in the viva. They say tongue, and yes, that is right, but they miss the full picture. There is a horseshoe shaped zone inside the mouth that is responsible for most intraoral squamous cell carcinoma. It runs along the lateral and ventral borders of the tongue, sweep across the floor of the mouth, and curves it toward the soft palate and tonsillar pillars. That horseshoe, just memorize it. Now, at the lower lip on top, 35% of all oral carcinomas, lateral trunk is 25, floor of mouth is 20, soft palate is 15. The buccal mucosa and hard palate, relatively they are resistant. If your patient had a suspicious lesion on the hard palate or dorsum of tongue, those are rare. But that horseshoe zone, never ignore anything there. Okay, you just have to memorize it. Coming on to the let's talk us about what actually causes this, and I want you to think about your patients while I go through this list, because some of them are sitting in multiple risk categories right now without knowing it. Number one, tobacco. Smoke tobacco is the single most important risk factor. 8 out of every 10 oral cancer patients are long term heavy smokers. Cigarettes, cigars, pipe, quit, all of it. Smokeless tobacco, snuff, and chewing tobacco also includes in this. Number two, alcohol. On its own, the evidence is less clear, but combine heavy alcohol with heavy smoking, and you get something called a synergistic effect. The risk multiplies, it does not just add. Number three, actinic radiation, sunlight. This is specifically for the lower lip, fair skin patients with prolonged sun exposure develop actinic cheilitis first, and that progresses. Number four, HPV, specifically HPV 16 and 18. Number five, immunosuppression. So, AIDS patients develop almost oral squamous cell carcinoma at a much younger age and without the usual risk factors. And then nutritional deficiencies, pre-existing oral mucosis, submucosal fibrosis, chronic lichen planus, all of these raise the risk. One risk factor is dangerous. Multiple together, that patient needs to be monitored very carefully. Now, coming at the mechanism or how it works is, so HPV 16 deserve its own slide because the mechanism is genuinely clever in a terrifying way. Normally, HPV has a protein called E2, whose job is to suppress E6 and E7. So the virus is keeping its own most dangerous parts under control. But when HPV integrates into the host DNA, it integrates at the E2 side. So E2 is destroyed, now E6 and E7 are completely uncontrolled. What does E6 do? It binds to P53, your most important tumor suppressor, and sends it through the ubiquitin degradation pathway that is gone. What does E7 do? It binds to PRB, another tumor suppressor, and releases E2F transcription factor. Cell cycle accelerates with both breaks simultaneously disabled. One virus, two suppressive pathways are destroyed. That is why HPV positive oral cancer behave the way they do. Now, that's what I have told you. You can see from here. Now we will talk about the clinical features. Here's the clinical reality, and this is the part that will make you a better clinician. Early oral cancer does not look like cancer. That is what makes it so dangerous. It looks like a white patch, leukoplakia, or a red patch, erythroplakia, or a mix of both, speckled erythroplakia, okay? And your patient feels nothing, no pain, no discomfort, they have no reason to come in. By the time it becomes a painless ulcer with rolled and indurated borders, by the time there is a tumorous mass or a varicose growth, the disease has already been there for a while. And when squamous cell carcinoma infiltrates deep into connective tissue, the surface can look almost normal, but underneath there is induration, loss of tissue mobility, fixation of the tongue, paresthesia when the inferior elbow nerve is involved, teeth loosening with no obvious periodontal reason. These are not subtle signs once you know what to look for. The problem is most patients only come in when they finally feel something, and by that point, precious time has passed. Let me go through the importance sites quickly because the behavior differs significantly by location, and the examiner will absolutely ask you about this. So, the lower lip will differentiate it, slow to metastasize. If you catch it before it's suppressed to the submental and submandibular nodes, nearly 100% incurable. That is the good news story for oral cancer. Talking about later tongue, moderately differentiated metastasis early to the submandibular and deep cervical nodes. 5 years survival in advanced case drops below 30%. Floor of mouth starts as erythroplakia, progresses to indurated ulcer, eventually fixes the tongue, moderately differentiated. So soft palate. This one is the most dangerous. Poorly differentiated, it invades deeply before surface ulceration even appears. By the time you see obvious clinical signs, the disease may already be in the cervical and jugular lymph nodes. Early detection as a soft palate is critical because the window is narrow. Now, coming back to the histopathology, 3 grades, and the grade tells you everything about behavior and prognosis. Well differentiated, look for carotene pearls, irregular, elongated, ready pecs pushing into the connective tissue. The cells still show evidence of maturation from basal to keratinized. It looks somewhat like normal epithelium, just badly organized and invasive. So, in case of moderately differentiated, little to no keratin, still recognizable as squamous epithelium, but with significant deviation from normal loss of cellular cohesiveness. Poorly differentiated, we will see no keratin, no architectural patterns, sheets of cell with severe pleomorphism and hyperchromatism. You look at the slide and it barely resembles the epithelium at all. As a general rule, lower lip tends to be well differentiated, Lateral tongue moderately differentiated, and tonsillar region poorly differentiated, and that gradient of differentiation matches the gradient of prognosis. So well differentiated, better prognosis; poorly differentiated, the disease is more aggressive and spread earlier. Metastasis. This is the part of the story where time really matters. Oral squamous cell carcinoma spreads through lymphatic invariant tumor cells enter lymphatic vessels and travel to the regional lymph nodes and set up secondary tumors there. When those lymph nodes expand enough, you can feel them firm, fixed, non-tender, that combination. Firm, fixed, and non-tender in the neck of a patient with an oral lesion is one of the most ominous clinical findings you will ever encounter. Okay, just focus on this. The submandibular and deep cervical nodes are most commonly involved for intraoral lesions. Lower lip lesions go to the submental nodes first, then submandibular, then cervical. If the disease travels beyond the regional nodes of the head and neck, it goes to the lungs and liver. At that point, you are managing a systemic disease, which is why the conservation always comes back to catch it early. Palpate the nodes every single time. TNM staging, you need to know this code for your Viva, FCPS Viva, not just the letters, but what they actually mean clinically. T is the primary tumor. T1 is 2 centimeters or less. T2 is 2 or 4 centimeters. T3 is greater than 4 centimeters. Okay, the primary tumor. The T4 means it has invaded adjacent structures, bone, deep muscle, skull. The TIS, this is carcinoma in situ. It has not reached the basement membrane yet. N is the lymph node status. NO means no suspicious nodes. N1 is suspicious palpable ipsilateral node. N2 is bilateral. N3 is a large fixed node, the worst. M is distant metastasis. MO means none. M1 means it is there. Stage 1 is T1 NOMO, small tumor, no nodes, no distant spread. Stage 4 is the combination of advanced tumor with bilateral nodes or distant metastasis. When examiner asks you to stage a case, go through TNM systematically. Do not jump to the stage number, show them the process. Coming on to treatment, the approach depends on 3 things: size, site, and stage. For early well-differentiated lesions like lower lip carcinoma, local excision is often enough. Clean margin, nearly 100% cure rate. For lateral tongue and floor of mouth, these lesions are usually diagnosed later, are less well-differentiated, and metastasize earlier. Standard treatment is surgery, often including regional lymph node dissection, followed by radiotherapy. Advanced cases bring chemotherapy into the picture as well. The prognosis differences between sites are striking. Lower lip caught early, almost always curable. Advanced tongue or floor of mouth lesion, 5-year survival drops dramatically. The lesson here is not which treatment to use. The lesson is that the treatment you use is directly determined by how early the diagnosis is made and who makes that early diagnosis. Obviously you, the dentist, you. So here is where I want to leave you. Every patient on this slide, every statistic, every survival rate, every case that ended badly, they all had one thing in common: they sat in a dental chair before they ever sat in an oncologist office. Someone examined their mouth, someone had the chance to notice something was not right. Be that person who notices. Know your horseshoe zone. Know what erythroprakia looks like. Palpate the lymph nodes. When something does not look right, biopsy. Do not wait for pain. Do not wait for the patient to come back in 6 months. The window in oral cancer is narrow, and the cost of missing it is a life. If this video helped you, subscribe right now, because the next video in the series is going live this week. Drop in the comments which module you want me to cover next. I will see you there. Subscribe, last night dentistry. Thank you and take care.